Hello everyone, it's Caitlin. We're going to talk about clinical paperwork and expectations. So we're going to begin each clinical day at 6:30. This means ready to go, not showing up right at 6:30. So we're going to begin the clinical day with getting your assignments and a pre-conference, which I know it's really early, so I don't expect much. And then we'll head to the unit as a group. We'll drop everything off in the break room and then we'll go out to the nurse's station and I'll help you find your nurse. And then you'll stay with that nurse, you'll get report, and then after you've received report on your patient, you're going to come to me and give me a little handoff and kind of give me your plan that you're going to do for the day. For the first clinical day, we'll go in and we'll do assessments together. So I'll give you a time in the morning when we meet for pre-conference when you'll be going for your assessment. Now for the clinical paperwork, every patient that you have will have an assessment form and a report form, and additionally you'll have to fill out a self-evaluation tool. Your primary patients will have the assessment and report form, but they'll also have a care plan, a CTT, and a medication worksheet, which we can talk about the medication worksheet at clinical. It's very similar to what we did today. The CTT will be a blank CTT, but you will insert the items that your patient meets according to that CTT. And your care plan, you'll choose one of the, I think we did 6 total. So you'll choose one that best fits your patient, and then you'll tailor those interventions to fit your patient as well. So this is the weekly appraisal form. You'll do this every week. You'll include your name and the date of care. And then you'll use that eval form that we use for midterm evals, and you'll look at the course objectives, and then you'll write just a little blurb, it doesn't have to be a novel, about what you think you're doing on an individualized care or safety and teamwork, and you'll fill out each one of these boxes. For example, for safety and teamwork, you can say, I helped Alexis give a bed bath, and I adhered to the proper PPE for a patient in contact isolation. This is the report form. It's pretty self-explanatory. This section people tend to have a problem with. Report from night shift is okay, but you should know who's taking care of your patient throughout the day. So you need to know what nurse has that patient and what CNA or tech has that patient. And those can be found on the whiteboard, which you'll learn in your scavenger hunt that you do for the floor. The rest of this information you just fill in as you've found either in report or during your assessment or in the computer. The one thing I want to spend a little more time on is the client assessment form. So you're going to write your name, the date of care, the patient's initials, their age, their gender, their height, their weight, their allergies, their medical diagnosis. The most important thing to make sure you don't do, which is a HIPAA violation, is write the full room number. Now this doesn't require a room number, but sometimes it helps you keep up with what patient you have. But if you write 441, that's going to be a HIPAA violation. All you need to write are the last 2 digits of the room number, so just 41. Just make sure you don't do that. For vital signs, you're going to always write the time here. This is kind of self-explanatory, but the biggest thing I want to point out is this O2 sat is when you write down their oxygen saturation to include their oxygen delivery. So you need to say, are they 99% on room air? Write that room air in there, or 2 liters nasal cannula. This is a pet peeve of mine. So always make sure you have the oxygen delivery. For pulse, you can write beats per minute, respirations, breaths per minute. And then for blood pressure, you should say whether or not it was the left arm, the right arm, whether or not they were lying down, sitting, or standing while you took that blood pressure. And temperature, you need to include the route just to make sure we can have a clear understanding as to what was the most accurate reading for that patient. General survey, you can go ahead and include, you just check these little boxes. You don't have to highlight them. One thing I added in is you can think outside the box. So if their vision is clear, you can just write that to the side. Or say they're not oriented to time. Over here you can write disoriented to time. Responds appropriately to questions. We do need to know how much they slept. It is becoming like the 5th vital sign or something. For pain, you want to include the time that you asked them their pain. If they deny pain, write denies, but also check vocal complaints of pain and none. Then we would circle that they have 0 amount of pain and that our goal is still going to be 0. These alleviating and aggravating factors are going to be NA or not applicable. We'll say at 10 o'clock she had chest pain. We would then say acute vocal complaints of pain. It's constant. Sometimes it could be intermittent. What was the pain level? Our goal might still be 0. A goal would not be 0 in case a patient was in chronic pain. Then they might be more a 3 for a pain goal. Describe that pain. If it doesn't meet those descriptive words, then you can write in your own words what makes it worse, what makes it better. Do we give any meds for that? The important thing is you need to do a pain reassessment if your patient did have pain. We need to make sure we're addressing that. We'll learn about pupil sizes in clinical, it sounds like, and the Glasgow Coma Scale. A lot of this is pretty self-explanatory. Cardiopulmonary, if you see them labored breathing, I want you to describe what you saw. Did you see nasal flaring? Did you see tripoding? What made you check labored? I want you to explain your abnormalities. You can check what your breath sounds were. If you don't have a chest tube, you can write none. Trachea hopefully is midline. If it's deviated, we've got a problem. We need to know if our rhythm was regular or not. For pulses, you write it here. If you don't feel a pulse, that's a problem. So please don't write 0 or absent. If that's the case, come find me. We should then Doppler our pulses. If we still can't find a pulse, then we need to write a big narrative note on A, that we didn't find the pulse, B, that we tried to Doppler it, C, we called the physician to notify him of this, and then D, what did the skin feel like? Was it cool? Was it discolored? Did we have any delayed cap refill? Cap refill should be brisk, less than 1 to 2 seconds. If it's sluggish, we need to say how many seconds it was. Was it 3 seconds? Was it 5 seconds? The more seconds it is, then the worse outcomes the patient's going to have. Sometimes our pulses are going to be hard to find because a lot of our patients are going to have edema, so we need to document that as well. A shunt or fistula is what patients use for dialysis. Hopefully we'll be able to hear a bruit and feel a thrill. Musculoskeletal, that's pretty self-explanatory. You just kind of check what you find on your patient. If you find abnormalities, like if you have absent bowel sounds, we need to be describing that and also tell somebody because that's not normal. For IV site, you can document where it's located in the right AC, what the IV site was. Was it a 20 gauge, 22 gauge? Did you see any drainage? Was it painful? Sometimes we can find the insertion and tubing date. Sometimes we can't, so just let me know and I can help you find those. We are not going to be assessing our IVs as far as their patency. We will want to know where they are located on the body. So you can write not assessed. A lot of our patients will have PICC lines or central lines, so we'll have to document that. When you say what type it is, so as far as a PICC line, you want to say how many lumens it has. So times 2, that means 2 lumens, or times 3, that means 3 lumens. Skin, uniform, warm, intact. If you've got problems with your skin, you need to describe that. And then you'd use this fun little diagram person here to document on the patient. You know how to do a brain scale, so make sure you do that. Circle your numbers here and then write them to the side and calculate your score. Figure out if you need to do any interventions. Same with the Morse-Falls scale and the VTE risk assessment. Psychosocial and spiritual, we do need to be asking these questions. I know they seem a little awkward at first, but they must be done. It's really important we know if our patient has any cultural considerations or spiritual needs or requests. Sometimes your patient will be a little standoffish with these questions, but you just need to explain to them in a professional manner. You know, my name is Caitlin. I'm here to do an assessment on you. I want to make sure that we're providing you the best care possible. So I have some questions to ask about psychosocial and spiritual. So bear with me while we ask these questions. Do you feel hopeful about everything? Another good thing I like to point out is, probably not a good thing, but a way to kind of phrase it to a patient is to say, you know, any spiritual requests. Because one time we had a patient that was, they were Jewish and they had an embolism, and so they were going to get heparin for it. Well, the patient didn't know that heparin had pork in it because that's not common knowledge for lay people. And so the patient received the heparin, and then later it was discovered that the patient was Jewish and that they said pork was an allergy. Well, the nurse freaked out because they were getting heparin, which is pork, but the patient explained it was a spiritual consideration. Well, then the nurse had to explain to the patient why that patient received pork. And essentially it caused a ton of moral distress for this patient because they were morally against it. Then we have got nursing care this shift. So just some important things for the side rails. You can write ×2, ×3, ×1. If it's ×2 all day, you can write ×2 here and just put yes throughout here. If you write ×4, that's a restraint. That's not okay. Bed should be in low locked position. If it's not, you need to explain why. Same with call light. It should be within reach, and we should be checking those things. Head of the bed, you need to give the degree, so 30 or 45 degrees. And same with turn and reposition. Were they on their left side, right side, supine? It's just good nursing documentation to say which side they were on. And AccuCheck result, what the result was and how much insulin they got. And then oxygen administration, were they on room air, 2 liters. Telemetry, are they on the monitor? Do they have SCDs on? You can write yes or no. Eyes and nose, we should be doing those even if they aren't strict eyes and nose. I want you to go ahead and record that. And then narrative notes. We should be writing narrative notes on our patient, especially for our afternoon assessments. This was just an example. You can pause it and read through that. That's a lot of information, but you should write something like at 12, patient reassessed, denies any needs, no changes in assessment, or you can write your new vital sign. Well, I guess you can write vital signs on that first page, but you could write no or breathing unlabored. Just write your changes that you found on your assessment at this time. And that's it for the assessment form.